Right, good afternoon. Welcome to the BDAU workshop on clinical datasets and session 3 of the workshops. Most of you were at the earlier sessions I did last week on primary care datasets, that's CPRD, clinical practice research data link, and HERS hospital episode statistics, which was the second session on secondary care data. But for those of you who weren't, I'll just introduce myself again. My name is Dalton Coker, and I'm the data officer within the Big Data and Analytics unit, which is part of the Center for Health Policy, sitting within the Institute for Global Health Innovation here at Imperial College. And the Big Data and Analytical unit is a unit that whose purpose is to use new and novel and innovative techniques to explore, analyze, visualize, and crunch data to support clinical and healthcare research going on in the college. So that's the unit, that's me, and today's topic is tertiary care or specialty specific data sets. Right, so we first need to establish what's a medical specialty or specialty for those who, the pedantic people who like to split hairs. So they can be classified along a number of axes. So you could speak of surgical or internal medicine. You could also think of medical specialties in terms of the age ranges of the patients. So if you're treating very young children, you're a neonatologist, treating babies within their first few weeks of life, treating young children up to, I think, about age 15 thereabouts. You're a pediatrician. If you're treating the very old, then you're treating the geriatric. So that's classification of specialty based on the age range of the patients being dealt with. However, within such a specialty, you could specialize further. So you could be a pediatric surgeon or a pediatric oncologist or a pediatric rheumatologist, etc., etc., etc. Another axis along which medical specialty can be classified is diagnostic or therapeutic. So you could have within, for example, oncology or cardiology, for example, you could have a diagnostic oncologist whose job is to analyze the symptoms being experienced, go through the scans, etc., all the information used in reaching a diagnosis. And then the therapeutic clinician, the therapeutic oncologist, would then carry out the procedure to excise the tumor in question. Another axis along which medical specialties may be classified is organ-based or technique-based. So in terms of organ-based, you could have a cardiologist or a nephrologist, or essentially based on the organ in which the clinician specializes or set of organs, that's what the specialty would be called. So what's normally called an ENT specialist, ear, nose, throat, that's also known as an otolaryngologist, I believe. And these are normally based on your Latin nomenclature for the organ in question. So those of you who studied classics or got some exposure to Latin and Greek, you are way ahead of me there. Along that axis, you can also consider technique-based medicine. So radiology or nuclear medicine or something along those lines would be a clinician defining themselves based on the technique they normally use. So this is just illustrating that clinical knowledge is a fairly wide pool, and with each specialty, the knowledge and skill levels becomes more concentrated but deeper. So a specialist would have the general body of medical knowledge, which they would need to have in order to have completed medical school and become a member of the Royal College of Physicians or whatever certification they have. But then to become a surgeon, they would have had to pass a series of exams and had to have carried out a particular number of procedures of a particular type and worked under an established consultant who has expertise and experience. So going to higher skill levels, enhanced skill levels, but deeper and much more concentrated within their specialty or subspecialty. So you could have somebody who's a surgeon, but then specializes in a particular type of surgery. But even within that specialty of that area of surgery, they may want to go. So you could have a surgeon who just specializes in maybe just a particular type of blood vessel. So that's how your specialties are organized. And here's a non-exhaustive list of medical specialties. Like I said, it's not comprehensive, so it's more or less alphabetical. I'm sure there are some I've missed out. Have any of you spotted anything obvious that's not in the list here? Any suggestions as to any specialty that's quite obvious that's not in the list?
Endoscopy.
Oh yeah. Yeah. And yeah, like I said, not exhaustive, but gives a fair. And if we go back to the axis along which they may be classified, endoscopy would be a technique-based, wouldn't it? A technique-based specialty. So that's a list of medical specialties, well, a non-exhaustive list. I've included general surgery, but not, for example, bariatric surgery, or I've included orthopedics and orthopedic surgery. So yeah, so that's our list there. And having looked at the list of specialties, I'll just give a tiny cross-section of a few specialty-specific databases available within Britain and a couple of examples from the USA. However, this is just the tip of the iceberg. There's literally dozens across the English-speaking world of medical practice. Well, more than dozens, beyond 100, if you include the entire canon of specialty-specific databases. But these are some of the best known and most widely used in research. So, well, within the NHS. So, there's the Bowel Cancer Audit Program, the National Confidential Inquiry into Patient Outcomes and Deaths, Bowel Disease Registry, Bariatric Surgery Registry, Esophageal Gastric Cancer Audit, National Cancer Intelligence Network, National Joint Registry, that's information on joint replacement surgery, and quite importantly, the performance of joint replacement implants. So we don't just, the NHS doesn't just rely on the vendors of joint replacement implants for their prognosis of how the implants will do. Their performance in patients is monitored as time goes by via the National Joint Registry. There's also the Myocardial Ischaemia National Audit Project, which looks at essentially heart attacks and outcomes from incidents and treatment of heart attacks. The National Congenital Heart Disease Audit, essentially for people who are born with heart diseases. The National Audit of Percutaneous Coronary Intervention. There's the NILS, National Reporting and Learning System, Office of National Statistics. Again, like I said, these last two are not specialty-specific databases, but they are relevant to this session, and for those of you who might be attending some of the other BDLU workshops, you might hear some further mention of NRLS and ONS, particularly those of you who might be interested in the ETL workshop that Joshua will be doing. Our unit has done a fair bit of work on the NRLS, which is essentially a system looking at adverse events, reporting of potential adverse events within the NHS, within NHS hospitals. Across the pond, in the USA, they've got a really good program analyzing surgical performance, NSQIP, National Surgical Quality Improvements Program of the American College of Surgeons. It's been assessed, and it's been found to be really to do a really good job in assessing the quality of surgery. It adjusts for does risk-based adjustments and case mix adjustments. So it really gives a good benchmark of various hospitals and various surgical teams compared to others. There's also the SERPS program, Surveillance, Epidemiology, and End Results program for Cancer Registry data. The advantage of the US Department of Health is where they do manage to coordinate things on a national level. They've got a database of 315 million odd potential data subjects, which gives a much larger data set than the UK, which is around about a maximum of 64 or 65 million potential data subjects. So even with having to clean the data and do your deduplication and normalization and all of that, the US data sets that are national give a richer source for data mining and insight. Right, so if we concentrate briefly on the UK's National Cancer Intelligence Network, it provides information on the diagnosis, the cancer type, the cancer grade, stage, and adjuvant therapy. Most of this is self-explanatory. The main advantage of the Cancer Intelligence Network is that, for example, those of you doing studies which involve work with the main primary care dataset, CPRP, would be able to get a link to the Cancer Intelligence Network for your cohort, which does enable you to track things like 30-day, 90-day, 12-month mortality, complications from surgery for cancer, how well the patient did following treatment, side effects of any adjuvant therapy. That would mostly be recorded within the primary care data set. So it wouldn't be in the Cancer Registry data, but once you link the two, you do get a very rich picture of what's going on and the extent of any sequelae, any side effects, and how many people they affect, how seriously they affected the patients who suffered those side effects. And on to MINAP, the Myocardial Ischaemia National Audit Project, which has been in operation since before 2003 and has had its findings made public since 2003. It supplies the participating ambulance services and hospitals with a record of their myocardial ischemia management compared with national and internationally agreed standards. So it helps, for example, the London Ambulance Service or Imperial NHS Trust to know where they are in terms of the best case and optimal standards, both within the NHS and across the OECD and EU countries. Again, some data details. It holds details on admission. So essentially, dates of admission and discharge and date and time of treatments, details of the treatments, etc. It currently holds records for just over 1 million admissions for myocardial ischemia, so quite a decent data set. That's your MINAP. And if we just take a quick trip across the Atlantic to talk about the NSQIP, which is a really, really fantastic surgical quality database. It's collected data on a wide range of quality indicators since October 2002. The data therein is from the patient's medical charts, which is a really key thing for a US clinical data set, because the clinical data sets in the USA mostly draw a lot of their data from claims data, which is not quite as good for research purposes as those which have data from the patient's medical charts. Like I was mentioning earlier, it's risk adjusted. So for example, caring for a seriously ill 80-something-year-old is very different from treating a fit, active 19-year-old. So the quality measures need to take this difference into consideration. And in some hospitals, you've got highly experienced surgeons, very highly expert surgeons who feel confident taking on very complex surgical cases, whereas in other hospitals, they would bulk at taking on very complex surgical cases and transfer them onto other hospitals. So the hospitals that are willing to take on more complex surgical cases more often would, if you looked at the raw data, tend to have much worse data in terms of outcomes. For example, in terms of deaths during surgery of 30-day, 90-day, 12-month mortality, in terms of complications post-surgery, in terms of medication that has to be prescribed to the patients post-surgery. But within NSQIP, it's case mix adjusted to account for the complexity of operations performed. It's based mostly on 30-day patient outcomes, which does provide a meaningful picture of care. So, if we just stop for a moment to think of the reasons for using specialty-specific data sets in research, these are just 4 of the reasons. Some of you might be able to suggest others. So they do provide deeper insight than just either the research team's data that has been collected, or than just your primary care or secondary care or ONS births and deaths data set. It enhances the granularity of analysis that can be performed simply because they contain such rich data, the vast number of variables, and the length of time they go back. Because of the length of time, some of these specialty-specific data sets have been in existence. They allow you to investigates trends going back, in some cases, decades, in most cases, at least 12, 15, 20 years. They enable you to investigate things like your incidence and your prevalence of specific conditions you might be interested in for your research. And by linking with primary and secondary care data sets and other data sets, they generate a richer picture of what's going on with your patient cohort. So I just explain what is meant by that by looking at a Venn diagram from some research led by Emily Herrett and her team that was published in the BMJ 3 years ago. So as you can see, this was to do with non-fatal myocardial infarctions, and each data set in itself is incomplete, but by studying the disease registry, hospital data and primary care data on myocardial infarctions, the research team was able to obtain a much more complete picture of what was going on in terms of myocardial infarctions for their study. So the numbers, as you can see in the intersecting sectors, speak for themselves, and in the sector where they all intersect, that's got the highest number. Well, it does show that there's quite a number of cases that are included in all three data sources, but that there are significant numbers of cases that are in just one or just two of the data sets. So by linking all three, the research team were able to generate a more complete picture of the incidence of non-fatal MIs. Right. Now, linking specialty-specific data sets to other data sets. Again, this is some technical detail for database analysts, or data analysts, or your database managers within your organization. So that's done by using a key variable that's in both of the data sets being linked. So for healthcare related work, it might be the NHS number. For anything looking at employment related research, you might use NI number or INDs or postcodes, something of the sort. Now, it's important to note that each data set in itself is pseudonymized or anonymized to minimize the chances of individual data subjects being identified. However, the more databases that are linked, then the easier it becomes to potentially identify individual subjects, data subjects, and that's why ethics approval has to be sought for such studies. Just something to note. And courtesy of one of our friends who's just completing his PhD research with. So the linkage would have been done through the CPRD people at the Medicines and Healthcare Regulatory Agency. So that's linkage from HES, CPRD, ONS, and National Cancer Intelligence Network. Okay. Now, there are a few limitations of specialty-specific data sets, but most of you who will be using the clinical specialty-specific data sets would either have the specialist knowledge, qualifications, and training to understand the specialist terms and terminology and nomenclature and the specific measurements and variables that it contains, or you'd be able to get advice from suitably qualified and experienced people. And comparing data sets for the same condition from different countries, or even within the same country from different providers, could prove difficult, as the methods for data input, collection, validation, checking, cleaning, normalization, deduplication, all of the data operations, the data ops processes may not be consistent across different data sets. So the SERPs for clinical registry in the USA and for cancer registry data in the USA and the National Cancer Intelligence Network in the UK are somewhat comparable, but not directly comparable. So because of the last points there, so that's something to bear in mind when you have certain people just throwing out statements that according to XYZ piece of research, certain things within the UK are below the standard of certain things elsewhere. You need to go back to the pieces of research that were being used as the source for that statement, and look at the data that those research papers used, and see how those pieces of data were obtained, compiled, collated, and put together before you can make such statements, or at least if you are the one writing up the research, in your discussion and conclusion, you do need to explain that there are differences and inconsistencies across data sets. So, right, I've made quite good time today. So we've got 15-20 minutes for questions. I hope I haven't been too boring, because one or two people seem close to falling asleep. Any questions that I can attempt to answer or note down for that email follow-up?
The slide you showed with the three overlapping heart disease sources, in that case, was the different coverage due to the fact that it's optional to go into any of them and it's just random luck, or is it due to different inclusion criteria?
The first reason. So it's optional.
Mm.
Nobody is really under any compulsion to have their data included in any of these sources. And within, for example, HERS, as I was reminded of last Tuesday, some patients can lodge a type 2 objection, which means that their data wouldn't be included in HERS. So, but that patient, if they do end up having certain side effects of their hospital care, and some of those side effects recorded in primary care, those details would show up in the primary care data set.
I mean, we've kind of had this conversation before, but just to sort of be clear, how many of those data sets have patient identifiers, like NHS number and stuff, and if so, do they require clearance with the GRO, like ethics committee, or is like a letter from your qualified guardian enough, or like what's the general situation with that?
They all have patient identifiers. Otherwise, how would you know what you do? Or you could, depending on the nature of your study, you could request simply aggregate data, so you would have just the numbers. However, if you requesting identifiable data or pseudonymized data, then you don't need ethics approval, or you need your, I think, the Caldecott guardian to authorize the research. So yes, they do all have patient identifiers. Any further questions, or if for some reason you do not want to ask the question here because you think it might be a bit too, it might seem a bit too obvious, or you are slightly shy, then you may email us at bdau@imperial.ac.uk. We will be happy to field any questions through either of these email addresses. So
I have a question, Dalton. Actually, I have two questions.
Okay.
One is it easier to get access to the specialist database than it is to, say, like HES or CPRD, which has a much more general population level type coverage? And the second question is, do you know of any attempts to collaborate on some of the specialist database to create like an NCD database or something that's more kind of top level but includes all these specialist database?
Right. I'll take the second question first. I don't know of any ongoing attempts at the moment to create an overarching data set that links all these databases together, and about whether it's easier to get access to specialty-specific data sets. Not necessarily. It depends on your research, on the purpose for which you're requesting the data, to whom you're making the request, and you know, it can be as difficult as requesting HES or CPRD data. Again, because with a specialty-specific data set, you're looking at, by definition, a smaller number of people. Therefore, the risk of identification is much greater. So the checking has to be done to ensure the integrity of the people doing the research and the intellectual rigor of the study being proposed. So again, that can take quite a bit of time in some data requests I've heard of. But again, if it's an amendment to an existing data arrangement, it's very quick and painless.
Is there any difference in the underlying participation? So if the patient, is the patient more willing to donate to a specialist database because it's helping their condition, and therefore maybe there's better consent models around that, or does that just not make any difference?
No. The patients do tend to be more willing to allow their data to be used for specialist data sets or specialty specific studies, because that's generally because a lot of these specialty specific data sets are for diseases which might either be leading to death or incapacitation or serious illness, and at that point where you're probably going to die soon or suffer greatly, you become more altruistic and want the data from your treatment to be used to help others. Whereas, for example, with the controversy over the care.data, where there was a general effort to link all primary care and secondary care data without prior approval of patients or doctors, just generally throw it all together. And there was a huge hue and cry across the media and the general public were very unhappy about that data being generally collected and pooled and used by private sector companies to improve their profits. So that's the main difference between specialty specific data and general medical care data. So yeah, the general idea about doctor-patient confidentiality is held very strongly by patients who see their GP for their general complaints, or even see a specialist or are sent to hospital for general secondary care. But for specialist care, for example, for cancer or heart attacks or neurological conditions or whatever, that are really serious illnesses, those are the kind of situations that cause people to become more altruistic in terms of wanting to release their data for the use of others.
Just to add to that, in the case of cancer, people don't even forward their data. The cancer registries go in and collect the data anyway. They have special dispensation to do that, and then it's up to the patients to then opt out to say, I don't want my cancer data on your database.
Yeah.
Can I just ask, when you say aggregate data, what kind of data is considered aggregate data? So, like if I wanted to get information about disease, say resource use, would I be able to contact these registries and ask, okay, for these kind of patients who...
Yeah. Aggregate data is just summary numerical data. So
prevalence and stuff.
Yeah. So it would be you would make your request clear in terms of for example the disease or the geographical areas you are interested in, whether you wanted them classified by males, females, by age group, ethnicity, whatever, and you get your numbers.
But it's not statistical analysis, it's just, you can't ask them to do like this, just analyze a certain patient group and get the information. It's more like numbers of.
Yeah. So it's quicker and easier to get. It may not be as useful to your study as the identifiable data, but sometimes the data with identifiers has to go through certain number of steps, and the time that the approval process takes may be a barrier, because you might have certain deadlines that you're working towards.
Sorry, this was covered last Tuesday because I wasn't here, but have you made these slides available online, and will you?
Yeah, they'll be made available, and if you just email bda@imperial.ac.uk stating which workshop you attended, you'll get the slides emailed to you personally. So, if there are no further questions or points to ponder, then thanks for attending, and please come tomorrow, same time, same place, where I'll be talking about open data. That's the data sets that are generally available to anybody to use as they wish.